One of the themes that came out of this book, and it wasn't entirely accidental. One of the things that came out of this book is how ripe the opportunity is to bring the health field in closer alignment with the community development anti-poverty fields. And I would actually draw your attention to David's chapter at the beginning of the book that does a really nice job of covering the history of the community development field, but also sort of suggesting, alluding to the fact that the future is in health, and that we should try it there first, and then roll it out everywhere else. So along similar lines, it's my pleasure to introduce Tyler Norris, and Tyler has been at Kaiser Permanente for many years, sort of selling this message internally. You know, how do we get our healthcare providers to think upstream and think intentionally about the social determinants of health? And then recently, Tyler has left Kaiser and is now running a new organization, which he'll tell you about, called the Wellbeing Trust. And I won't put words in your mouth because I'm sure you'll say it much more eloquently. But basically, he's trying to take this message and take it nationwide. That we need to think holistically about people's health, spiritual health, emotional health, physical health, mental health. So again, my pleasure. Tyler, come on up.
Thank you. Ian, thank you, and wonderful to be here with all of you. I've been on the road for 2.5 weeks, and I came home last night to my beloved Oakland, and the streets were alive. It felt so good. So I'm in the glow of that, and I didn't get much sleep because I lived right downtown, and it was very alive till very late, but a lot of fun. So I'd like to say that I may be one of the handful of people here in the room from the health care sector. But I'd like to begin by acknowledging that everyone is in the health sector. And we may be the folks who take up about 18% of the gross domestic product, $3.2 trillion, 20 cents on every dollar, and may deliver exquisite world-class care to people who can afford it. But we are also delivering second and third-rate population health outcomes for that. And in fact, we do measure outcomes in terms of quality and cost and great clinical procedures. But if we're held accountable for health outcomes, what should we say? Mixed results. Shame on you. Pardon me? Neener. Yeah, thank you. We have a long ways to go. Some of you know I often think about my daughter. I was talking with her this morning on the way in here. She often points to a recent report from the Institute of Medicine that articulates that after a century, the previous century of increasing lifespan by 23 years, many children born today will live 5 years less than their parents. And her admonition to me always is, what are you all doing? And I think that really is the question when it comes to what are our outcome on our watch, as Eliza is saying. What are we actually doing, and why does this point of partnership, which has come up so much, become so important for the health sector? So I'm going to talk a little bit about Kaiser Permanente, where I was proud to spend many years, think very strongly of that organization. And then just to briefly name it, I was fortunate to now be leading a new national foundation called Wellbeing Trust, endowed by the Providence St. Joseph Health System, to build the mental, social, and spiritual health of the country. And much of what that is about is what are the policy changes and the investment changes we may need to make to have a measurable improvement in health status, particularly on those most sensitive indicators as mental, emotional well-being, anxiety and depression, substance use, and so many things that are driven by community-level trauma that are at the root, that are addressing the root of equity challenges in our communities that are showing up in so many of us struggling mentally and emotionally. So let's see, place to begin. It would be inappropriate for me to not stand up here and acknowledge that while only 10% of what creates health may have to do with access to quality medical care services, let us not forget that is an extraordinary risk in this moment. If what happens in Congress that is played out with votes coming up very soon occurs, we may find that the gains, and the CBO is suggesting, whatever the plan may look like, 23 million Americans may lose access to care outside of the emergency department, which of course occurs at many times the cost, and people who have much greater acuity of illness by the time they actually get there, with all kinds of impact to our employers who are not ready, ready to work, and presentism, et cetera, to schools, to our ability to support our families, et cetera. It puts many Americans back once again one serious disease or illness away from bankruptcy, as the leading cause of bankruptcy in the country is health issues. And if we, in fact, lose essential health services, which are on the chopping block, the very thing that we're focusing on, anxiety, depression, substance use, are most at risk around that. Many of you may know, if you just want to talk numbers, we're in the outcomes conversation here at the Federal Reserve Bank. What are the investments? Depression in this country costs $400 billion a year. That's in direct costs and indirect to workplace, et cetera. Anxiety, $300 billion a year. The opioid epidemic is taking just shy of 60,000 lives a year. Suicide rates in teens and veterans. So what we are placing at risk by undercutting people having a medical home is profound. And I want to talk about other topics, but we have to make sure that we preserve that primary element if we're going to address this. And maybe most pernicious of all, and I was having a very interesting debate with a congressman from Idaho the other day who was defending his strategy and his moderation of the debate, who said, well, I really don't know where prevention is in that strategy. Let us remember that the Prevention and Public Health Fund is zeroed out. So all of the things that are part of our nation's strategy. So that I just wanted to start with that because it is so fundamentally important to the well-being of the country. However, then there's the other 60, 70% of what creates health that we know we need to be able to address, that not only have to do with lifestyle and behavior factors, but take place in the context of place and power and the conversations we've been having this morning. I think what is very true for all of us in the health sector here, including my colleagues at Kaiser Permanente, a number here, and I don't know who else is from the health sector, but housing policy is health policy. Food policy, food investments are health investments. Early childhood development, Child Nutrition Act, community development finance strategies, block grants, living wage, green jobs. This is all health policy. These are the determinants of health. And those are, as we know, significantly on the chopping blocks. And it is vital that we not only make the kinds of investments we're talking about here, but making the investments in the policy and building the constituency, Fred, that you were talking about, where those large dollars are, and so key. Health and the economy benefit from our understanding that the social determinants of health and well-being and long-term prosperity of individuals are the same. They are fundamentally the same. And we do that well, we have solutions that solve many issues at the same time. In response to thinking about what's on the block right now, I was thinking I grew up in the state of Idaho. I had an old rancher friend of mine who reminded me that it's a bit like eating your seed potatoes, your seed corn. It sort of satisfies you for the moment, but in the long term, it just forestalls devastation. So let us be thinking more about what a long-term strategy really looks like. So this combination of investment in very, at times, profitable sick care services and an underinvestment in the determinants of what creates health drives these rates of disease, which actually make healthcare more unaffordable because of the demands on the delivery system driven by chronic disease, et cetera. So we have to really be able to think about that, particularly for disinvested communities that are chronically disinvested in. So you get what you reward. Now, as I've often spoken about Kaiser Permanente, which, not just to speak about Kaiser, but it's really a matter of looking at the horizon, right? Where an organization is at risk as an insurance health plan and provides the care. That means unlike the bulk of healthcare that actually makes its money from the volume of services, Kaiser Permanente needs to produce value. because that's its business model. The same thing is true of increasingly large amounts of the healthcare sector. I was actually back in Idaho again the other day with a friend of mine runs the largest health system there, St. Luke's Health. Red state, conservative organization in many, many ways. They have a small health plan. A year and a half ago when I talked to him, it was generating 7% of his revenues, and 93% of his revenues were still from beds full, right? So his CFO is, I want still beds full. Last week, we were talking 30% of their revenues are from their health plan, right? Now the CFO's going, beds full, beds empty. He's going to cross that 50% threshold in about 18 months. So as much of the health sector moves towards a value-based system, we're rewarded for value, we're going to have to partner with the producers of health, which is housers and food development and jobs and everything that's been talked about, and see ourselves as buyers of health, not just producers in ourselves. And I think that's a particularly important piece. So a couple of things I want to mention, and then I hope we'll move towards dialogue. 5 things. One is we need to make sure people have access to a medical home with integrated medical care and health, physical health and behavioral health services. Absolutely, number one. 5 to 1, 7 to 1 return on investment and prevention. Secondly, we need to ensure that the grants and the investments we make have sufficient dose. My colleague Pam Schwartz is in the room, who with others at Kaiser Permanente have written beautifully about the importance of reach, intensity, and duration that are long enough and strong enough to have a population-level health impact and not just do good things. If we're going to move from doing good things to being accountable, we need to make sure that we have that kind of dose in our investments. Third, we need to make sure that assessing non-medical needs, social needs, become a standard of high-quality care. Not a nice thing to do, to ask someone about housing and food security, but in fact a standard of care, and that what comes along with the assessment becomes referral, warm handoff, to an organization that will help them meet that. Now this comes into the contracting piece where we're talking about, whereas healthcare becomes more at risk, we now not only need to partner, but partner with the organizations that are health producers that are in fact needing to be in partnerships. As long as we sort of, I keep not wanting to use this word, let's just say string along nonprofit organizations with small grants, instead of contracting with them with recurring revenues to meet those needs, then we can start to really be at-risk relationships with the data, with the reimbursement, and we start to create the kind of economy that we really need that strengthens that and brings the producers of health back into the economy, if you will, the economy that values health. We need to, fourth, support our anchor strategies, meaning using our investment portfolios. Healthcare has over $1 trillion invested on Wall Street, a ton of money. And part of what we need to do is to help our healthcare organizations, particularly the nonprofits, make sure they're investing those portfolios in what we're talking about here. Our hiring is 6% of the economy, 7 to 8% of the economy, and procurement, again, almost $1 trillion a year. The ability to buy local, buy from women and minority-owned firms, really drive that local economy, spin the local flywheel, are all parts of what we need to be asking of healthcare, of local government, of universities and other anchor institutions to have enough dose. And we need to continue to have this movement towards value-based care. Communities are showing the way. There's at least 1,000 communities across this nation that are doing place-based collaborative planning about what improves health. And they will talk about living wage jobs, housing with support services, scaling access to healthy, fresh foods, community safety, addressing childhood, adverse child experience and adverse community experience, the toxic stress that is upstream, and those things that improve health. There is an extraordinary groundswell in this country of investment strategies that are not on the radar nationally because it's too localized. And so I think one of the opportunities we have is to lift up what we're seeing that business, government, nonprofit, Republican, Democrat, across sector are saying, is working in communities and make that a policy agenda in our state houses and in Washington. That's the kind not only of investment strategies that are going to work, but the kind of constituencies we're going to have to break through to break the toxic partisanship that's actually locking us in to default strategies where we're getting what we get. You get what you invest in. I want to close with a challenge, an invitation, really, because I don't know the answer to it. But if we're going to invest in outcomes, and we want to take a generational approach, I'm thinking I invoked my daughter here a little earlier, what do we need to be thinking about in the direction of what I've been thinking about as child well-being bonds, or what we called in New York, we nicknamed bright eye bonds, right? That would take a generational view for this country and would not only, what it would provide the services for kids, preschool engagement, reading, cooperative play, the arts, what kind of services would need to be brought together that would eventually reduce the end of pipeline costs, Sam, and what you were talking about in corrections, in sick care, and in so many other places in the world. That would take all of us and the right research in order to make that possible. But I think we have the will to do that. So I'd like to make sure that part of the conversation is how do we use the extraordinary talent, the amazing assets in this country, the actual transpartisan agreement about what needs to happen, and do something that's worthy of who we are in our lives. Thank you.